here, and just want to let you know. So I'm from Florida, southeastern USA, and there, our mascot at our university is the alligator. So you may see some alligators, and if you ever come to Florida, I promise you, you will see a lot of alligators. I am a physiotherapist. That's how I've practiced clinically, and my PhD, my research training is in the biology of the respiratory muscles. So I'm very, very interested in how breathing works and how our muscles need to work together in order to get the job of breathing done so that we can stay breathing without any help. And so the focus of my work is looking at the muscles responsible for breathing and then also for clearing secretions, for airway clearance. And so this picture here is a magnetic resonance image, or MRI. And so this is an MRI of a boy with Duchenne muscular dystrophy, not with a centronuclear myopathy. But you can see those dark shadows there are his lungs, and you can see his heart beating in the middle there. And you can see right on, I think, maybe, well, you can see right here this beautiful dome shape is where the diaphragm sits. It's a very thin, almost like a fan-shaped muscle. And it's just this beautiful muscle that every 3 to 5 seconds contracts. We don't have to think about it. It just does the work of breathing. It does the main work of breathing. But you can also see, so the diaphragm sort of pushing the contents of the abdomen down so that the lungs can expand and fill with air. But you can also see out to the side here that the chest is expanding out this way too, right? It goes out to the side, it moves up, and so there are also helper muscles that also help carry out the work of breathing. And so we're very interested in learning how these muscles coordinate and what sort of a job they need to do to keep individuals breathing without support. And so my research asks some questions about breathing, and we're very interested in these questions in the context of centronuclear myopathies. First, how much support do people with centronuclear myopathies use, both at night, overnight, and then maybe they use support during the day as well? So how much support are people using? And then do people use support non-invasively with a mask or the pillows, or do they use it invasively with a tracheostomy? And then if they're children, how, as children grow, and maybe their spine and their rib cage configuration, it gets stiffer and maybe develops some changes in the architecture of the chest, like a scoliosis. So how does breathing change as people grow and develop? And so we look at some specific measures. We look at the size of the breath volume, the strength or the tension that the muscles of breathing generate, and we look at just how much time kids and adults spend off the ventilator. And this was a picture. This is a child with X-linked myotubular myopathy. We are measuring the strength of the muscles that pull in air, the inspiratory muscle pressure, maximal inspiratory pressure. And so this child came off the ventilator for about 20 seconds and really tried to pull in as much air as he could or make as much tension as he could in that pulling in motion and participate in that test with us. He did very well. And then the last question that I'm very interested in is, can people with a centronuclear myopathy, do they have a functional cough? Right, so that's maybe a little off topic there, but not really, because when we think about what we need to do in order to breathe independently and to do well with it all day long, first of all, your brain has to have the drive to breathe. So you have to know that you need to take a breath and then be able to tell your muscles to take that breath. So from the neurological standpoint, and we found that even boys who are placed on the ventilator very early and don't use their muscles very much, they still retain that drive to breathe. So that's good to know. The second thing is ventilation. And we sometimes think about breathing when we think about the lungs, but it's the muscles of breathing, of course, that generate the pressure to inflate the lungs. And so breathing's not just about the lungs, it's about those muscles as well. And so having the ability to all day long generate that tension every 3 to 5 seconds is what will cause ventilation to be sufficient. And then, of course, the third big thing people need to do is to clear secretions. And so that would be to generate a big functional cough. I won't cough into here. So those are the 3 things we're really concerned about. And of our respiratory measurements, this is another maximal respiratory pressure test. This child does not use a ventilator, so we use a different set of equipment with him. So we can look at the rate of the breath and the inspiratory flow that's generated. Those are some simple, non-invasive ways to look at the drive to breathe. Then we can also measure, again, the size of a breath using a sensor that detects flow that we can connect either to a tracheostomy tube or here, like to a mouthpiece that this child is using. We've talked about maximal respiratory pressures. Again, those are things that, those are tests that test tension or strength of the muscles, either pulling in or blowing out air. And then we just use some very simple software that works with commercial ventilators that looks at how much a patient is or is not using their ventilator. So that gives us an idea on a regular basis, how often is a child coming off and for how long during the course of a day. And then finally, we look at what's called paradox, or whether breathing muscles are working in a coordinated way. So paradoxical breathing would be uncoordinated breathing. For secretions, we can, number one, determine if a patient can cough voluntarily or if they can cough when we kind of tickle the back of their throat. So either a voluntary cough when we ask or a reflexive cough when we tickle the throat. And then when a child coughs, we can measure the size of the flow when they cough out. And all of this is really to give us an idea of how breathing changes over the course of growing, developing, and aging in people with centronuclear myopathies. It's important for us to understand this for 2 reasons. Number one, as you know, the centronuclear myopathies are rare conditions. So we don't know a lot about them beyond maybe this many folks use support and this much is full-time. So we need a little bit more objective information on how these breathing muscles are functioning just naturally over the course of time. Because, our hope is, whether it's MTM or whether it's another centronuclear myopathy, we hope that we hear all about treatments and therapeutic options for many of the rare diseases in the future. But the first thing we need to know is, how do we expect the condition to change over time? So I'm going to give you an example of how our clinic has used just measuring breathing function in the context of a clinical trial. So the University of Florida had a funded gene therapy study, and it looked at another rare, serious condition called Pompe disease, another neuromuscular condition. And all of the children that we worked with were using ventilators for a long period of time, at least a year. And so this was a first-in-human study, so it was the first time this particular gene therapy was ever used in a person. So to do that, the FDA, our government agency, they allowed us to put it in one place, in one muscle. And so the one muscle we chose was the diaphragm, because it's the best muscle, right? So because it's the most important muscle, really, for these children. We thought, if we can make the change in helping kids to take a bigger breath and to stay off the ventilator more, we might be able to measure that. But we really didn't know, in children who use a ventilator all day, what children objectively can do with regard to the size of the breath they can take without help, and the tension they can generate, and whether they generate a cough, and how long they're spending off the ventilator. So it was important for us to know that so that we can determine, was this gene therapy effective? And so we started this trial. This trial was published, the interim findings, a couple years ago, and in fact our final paper is about to be out this spring, so we're looking for it any day now, so excited about that. Let me just walk you through this real quick. The design of the study was that since it was a first-in-human study, it was most important to know what the safety of that gene therapy was. That was the most important finding. So we worked with patients. We did some tests before they ever got the gene therapy, about 2 months before they got the gene therapy, and then we followed them all the way out to a year after. Now again, we want to know, does function change in the absence of a treatment? We measured respiratory function as our secondary outcome measure or exploratory outcome measure. And so the first couple of months before the patient got gene therapy, we worked with the patient and had them just spend a little time off the ventilator every day if they could tolerate that. We also gave them a small training device to use that we use in the intensive care unit to help patients after surgery to get off the ventilator. And then patients received the gene therapy and they just continued those exercises. So we had exercise off the ventilator only versus exercise plus the gene therapy, the injections of the product into the diaphragm one time. And this is the picture of the respiratory training device that we use. It can be connected directly to a tracheostomy. And those exercises lasted about 20 to 30 seconds at a time, and we did a few of those every day. So they were very brief exercises for the children. Those exercises were well tolerated, even for children who only spent a minute or two off the ventilator every day. They were well tolerated, no adverse events, oxygen levels were very good, heart rates were very good. But exercise alone did not change the strength of children. So these letters here, MIP, stand for maximal inspiratory pressure, and that's a strength measure. And this here, VT, that's tidal volume, that's how big of a breath do kids take. And this was the change after exercise alone, and there really was no change. Zeros in the middle, and we were hovering around 0, so did not really change function. Then we measured after gene delivery, and this is gene delivery here, and this is all the way up that last year that we followed them. And what we saw, we actually referenced this to every child's normal or function at gene delivery, because some kids could do a little bit more. So we rated them all as this is their baseline, their 100%, and then we went up from there. So all of the kids spent more time and took bigger breaths off the ventilator at that 1 year point. And some kids made smaller gains. We had one who made a huge gain, as you can see, and that corresponded to a just shy of 3 hours off the ventilator, starting from about 8 minutes off the ventilator. So we did see changes, and it helped us to understand that this could be a potentially helpful therapy if we gave it to more muscles, because we had that reference or that baseline value. We had a little bit of an understanding of how those muscles were functioning in the absence of the treatment. And so in central nuclear myopathies, we're also studying breathing function. We're using a lot of these very same measurements. And so we have one of the largest clinical muscular dystrophy care centers in the southeastern U.S. At UF Health, at our affiliated healthcare institution. And so we see several children for their routine clinical care. And then also we've gone to the the MTM CNM family conferences and done some data collection at those family meetings for people who were interested in participating. So we have a natural history study. And a natural history study can be following people over a long period of time. But we recently published really our first large collection of data at the first myotubular myopathy meeting we attended in the US. And that's referenced down here in this small text here. So that was published last year. And it's almost like taking a snapshot in time, taking a picture in time of how those individuals were functioning at that time. We did not track them. There were 14 participants, and 10 of them had a confirmed X-linked myotubular myopathy diagnosis. There were others, ryanodine, Dynamin, and a couple of unspecified CNMs as yet undiagnosed. So it was a single visit. We saw kids aged 1 to 26 years, and almost all were males. And almost all used a tracheostomy, and most of them stayed on the ventilator for more than 23 hours a day. There were some kids who would come off 2 or 3 or 4 hours a day, but most were on there 23 and a half plus hours. We're also actively involved in another study at UF, and this is funded by Audentes Therapeutics, and this is more of a longitudinal study. So instead of a picture, we're taking a movie now, and we're following kids every 6 months, and we have funding to follow them for a year. So we're working with 10 subjects. This is just with confirmed X-linked myotubular myopathy, though, over that year. And we're studying boys aged, I guess, 0 to 14 years. We don't have any kids under the age of 1 right now, but we've got 4 boys in each of these age categories. And even though we've got very little overlap between the data we published last year and these patients who are in this study, they're almost all different. But still, we see that most kids in our study here in the US have received a tracheostomy. Most of them use the ventilator for more than 23 hours in the 24-hour day. So the picture in time that we took from our published report showed us that actually a large amount of our kids had some amount of paradoxical breathing or uncoordinated breathing. And we found that kids who had more uncoordinated breathing, where the chest and the abdomen weren't expanding together when they take a breath, they tended to take a smaller breath. And I think I'm going to skip over that so we can maybe talk a little bit more about some more nuts and bolts on that. I think you guys are going to have some other more practical questions, so I'm going to skip over that. Just to give you an idea, though, this shaded area here, this is the size of a breath we're looking for kids to take just at rest. And so we reference this to how much a kid or an individual, there were adults in this too, how much an individual ought to weigh for their size. Because our volumes referenced to our size should be fairly stable throughout our lifespan. So a lot of our kids were well below where they should be, which sort of makes sense that they were using support most of the day then. We also found that kids or individuals who spent more time off the ventilator had retained greater ability to make pressure with their muscles, or greater strength with their muscles. It was statistically significant on the inspiratory side. So kids spend more time off the ventilator and they can generate more of that inspiratory tension. There appears to be a trend on the expiratory side, but that was not significant. Now, a ventilator helps kids draw air in, or helps individuals draw air in. So it does help the inspiratory muscles more. Exhalation tends to be passive when we're not working hard. So the ventilator doesn't help the expiratory muscles as much. And we're seeing on the 12 children we're studying right now on the Audentes-funded project, we're seeing the same trends, a little bit more variability. And in fact, these children may actually be a little bit weaker, but we're seeing the similar trends. That individuals who spend more time off the ventilator tend to retain their strength. We also, when we look at age and retaining strength, we see a couple of things. Number one, you can pick out which one of the 12, which age category, that one child who doesn't use the ventilator all day, you can tell he's in the older age group. So I've starred him up there because he comes off the ventilator when he wakes up and he doesn't put it on until he goes to bed at night. So when we sort of take him out of the picture, we can see that as kids get older, or older kids tend to have lower maximal respiratory pressures. All right, and here again, in the gray shaded area, now younger kids generate a little bit less pressure, so these bands are a little bit wider. But these are the zones where I would expect maximal respiratory pressures to be: inspiratory pressure, expiratory pressure. So once again, our kids are well below where we would expect them to be. But still, some kids are retaining 50 to 60% of where I'd like them to be, and that's good. What we saw on our published report was that when we tracked the full-time use of the ventilator to the strength of the inspiratory and the expiratory muscles, we saw that the longer you use a ventilator full-time, the lower those pressure measurements tend to be. So the muscles aren't used as much over time, and the ventilator's doing the job of taking over the job of breathing. So the muscles generate less tension over time. And we're finding, in this longitudinal sample so far, we're finding the similar trends. But we're really very, very interested in the later time points for these boys, because we've seen some of them again for 6 months, but we'll be seeing all of them at 6 months and at 1 year. And so in 2017, we'll be very, very interested to see, has function changed much for these boys over the course of this year? Or do they remain relatively stable? So that's a big question for us. And then finally, the functional cough. We look at cough in 2 ways. Well, actually 3 ways. We always observe and annotate if we see a child spontaneously coughing, trying to clear his own airway. And then we ask the children to cough. And then finally, we see if the children can generate a reflexive cough with tickling their throat or with suctioning maneuvers. And what we found in the published report from last year, from our family conference visits, that only 2 of the 14 individuals we worked with generated a functional cough, and only 1 of the 12 on our current longitudinal study has generated a functional cough. So what can I tell you? Well, we've still got a lot more to learn about respiratory function in the central nuclear myopathies. Our University of Florida central nuclear myopathy database it's approaching 30, and we're getting a lot more variability. We've got more kids with Dynamin 2 now. We've got some kids with Titan. We've got some manifesting carriers. So we've got a lot more diversity in that data set, and we're interested in all of these centronuclear myopathies because we want to learn as much as we can about them. What we found is that even children who use a ventilator more than 23 hours in a day, their function is variable. Some kids still can take a bigger breath. Some kids can generate more tension with their respiratory muscles. So even when we think a child is using the ventilator all day long and just coming off for little bits at a time, we still may be retaining some function, and that's important because we may be able to tap into that once there are some therapies for muscle disease. Those children who do spend more time off the ventilator are stronger. We don't know if children spend more time off the ventilator because they're stronger, or if spending time off the ventilator keeps a child stronger. So we're not sure which is which. But what we can say is the two seem to go together. And then strength does tend to decline the more years you use the ventilator full time. We also know that cough function is limited, and that's important to us as well, because again, we may be able to come off the ventilator, but what happens is when that positive pressure is removed, the secretions can be mobilized, and kids will need to move that mucus up and out. So it's very important, even if kids can contract and generate tension to move air in and out, we still have to think about airway clearance, and are they going to be able to clear secretions, because that may also limit their ability to stay off the ventilator. So here are a few thoughts on airway clearance, and these thoughts and considerations really have been driven. We tend to use the British Thoracic Society guidelines. We think the American Thoracic Society needs to do a little more catching up. Their guidelines for respiratory function in neuromuscular disease, they're a little behind the times. The British are more recent. So I would refer you to that one. But what is found is that there are multiple different airway clearance techniques, and they do seem to be very helpful. There have been studies that have shown that routine practices of airway clearance helps individuals have reduced hospitalization visits for respiratory infections, and that seems to translate to some increased survival as well. So having an established routine, finding what works for you as far as airway clearance, I would suggest it. So if you've got, maybe a kiddo at home who hates his airway clearance routine, then maybe we've got to talk about, is there something else we can do instead of, or in addition to, or find a way to make it less time, less arguing, those types of things. Because the best method may depend on how old the child is, how cooperative the child is, or teenager or adult, or, and also how much they're able to help, the degree of weakness, because some will require working together. And then if you use a cough assist machine, like this little guy's using there, on the littlest individuals, so we're talking 2 years and below, we're still trying to find out what the most effective airway pressures are, pressure settings are for those littlest individuals who use a cough assist. So there is some research going on to that yet, but I don't think we know the answer on that yet. Some additional thoughts on maintaining activity. So sometimes just changing ventilator settings depends on the philosophy of your muscle specialist and your pulmonary specialist. At the University of Florida, we tend to prescribe either a range of settings, or some of the newer ventilators allow us to set 2 or 3 or even 4 different channels. And so one of our channels might be an exercise channel. And that could be a channel where the rate is reduced, the mandatory rate is reduced, so children have to trigger it more, so that they're getting that. They're telling the ventilator when they want the breath, when they need the breath, versus the ventilator going when its timer says to go. And then, again, also not only the timing and the length of the breath, but delivering maybe a lower level of support, so the child has to pull in a little bit harder. What we found is with high volume, high rate ventilator settings, there've been some, they're a little bit older studies now, but it shows that when you turn up ventilator settings super high, of course, patients don't have to help as much. So even the brain begins to not tell the muscles to work. The drive to breathe from the brain is very, very decreased. So the activity of breathing becomes much more passive. And exercise does seem to preserve function in the neuromuscular diseases, but the long-term exercise studies are very limited. There have been some studies, 3, I believe, that have been published in Duchenne muscular dystrophy and spinal muscular atrophy. And so those are also conditions where children require support and will require eventually full-time support, but the mechanism of their disorder is different. So we don't know that we can make exact comparisons between all of these conditions. So approaches that we use clinically for children who come in and come in with an exacerbation and need to be reconditioned here in the hospital or in the clinic, is that we may prescribe some light activities that can be done on most days of the week. I don't know about you, but I don't exercise every day of the week. Even as a physio, I don't do that. So we say most days of the week, and that's usually, again, using that exercise setting on the ventilator or coming off for short periods if that's been determined to be safe. But if children do come off the ventilator, then they may need a humidity exchanger or a way to maintain moisture, most definitely. And then we may prescribe more intense exercises, strength training exercises. I think you saw the picture of that little device on that guy's tracheostomy tube. What that is it's a spring-loaded device, and it almost acts like a weight that individuals have to kind of pull in against as they take a breath. So those are more intense. They're designed to increase strength, and so those sessions tend to be very short, like 6 or 8 or 10 breaths at a time, very, very short duration regimen. So we've seen some evidence for this, again, in muscular dystrophy, children and adults with Pompe disease. There's a case study in myelomyopathy that it appears that this is a safe intervention. It may be effective in some individuals, but I think we've got a whole lot more to learn about it. We found it helpful clinically for individuals, again, they've had an acute problem or an acute surgery and they need a little bump, but we need to learn a little bit more about that. So that's the content I had prepared for you guys. I'm happy, so this is one of our friends here in Gainesville, Florida. If you'd like to come and visit us, you've got lots of these there to welcome you. Mickey Mouse, he's not that far away either. So, and here's, it's hard to see. It's in the corner here, but there's my contact information. If you do run across questions, it's bksmith@phhp.ufl.edu. And I'll keep it on there. But I do want to acknowledge I've got a ton of collaborators at Florida, but also many outside of Florida as well. Friends here with the association in the US, the UK, and Germany, funding sources, and then, of course, our patients who are awesome, and we have a great time with them. So any questions you guys might have, it's bksmith@ufl.edu. So what questions might you have? Yes.
My son currently has only night support. And my question is this synchrony between child and ventilator, is it important when the child is supported only during the night? Because I've heard controversial opinions from doctors. Some of them think that this coordination and synchrony is important, and some think that it is not important at all, and this is good for the child when he's at rest at the night, and the ventilator works for him, increase lungs as much as possible, providing lots of oxygen. So what is your opinion on the matter?
Yes, that's a good question. And so, so how much support to use at night when you're using only, when you only need help at night? Well, a couple of things change at night. Number one, when we go from an upright posture to horizontal, what happens is that the diaphragm in this position goes straight down. And when we're in the recumbent position, in the horizontal position, it does have to work somewhat against the weight of the contents of the abdomen. And so it's in a lower biomechanical position. It's not as good a position to generate tension. So that's one thing. And then the second thing, when we sleep, and especially as we get into those deep phases of sleep, the drive, the inspiratory drive decreases. And in particular, in the accessory muscles,